Okay, so now it's time to get into our second degree AV blocks. Now recall there are two types, but this is a true block of electrical conduction. So if there's a block, that means nothing's getting past it to go down to the ventricle. So we're going to see that the characteristic pattern definitely changes here. Now, as mentioned, there are two types. In type 1, the PR interval will actually change as that block gets progressively longer and longer and longer. And then we actually have a drop where we don't see a QRS wave. And in type 2, we have that consistent delay in the PR interval, but then all of a sudden an impulse is blocked. So let's look at those a little bit more detail. In type 1 second degree or second degree type 1, it's known as Mobitz type 1. And you're going to notice that we have a Mobitz and a Winkelbach, and that's because there was two scientists, we'll talk about them briefly, involved in this discovery. So what is happening here is the SA node is sending its message to the AV node, and he's holding this message a little bit longer each time until one time it just doesn't send the message through. So we have a longer drop. Then you have a Winkelbach. So here's where the second name comes in. We have the Mobitz type 1, but it's also known as a Winkelbach. So imagine this is that 5-minute delay that you had getting to work, or I guess would be coming home from work. We want the QRS to be coming home. When the husband leaves work and he's on his way home and he comes up to that sidewalk that's being reconstructed and he has to wait a few minutes before he gets past that. That was our first degree AV block. Now he comes home, he comes up to that sidewalk construction, and the first day he's a few minutes late, he gets through, not a problem. The second day he comes back to that sidewalk construction, and today they've got the whole street torn up, so he's actually got to go a block over and down to get home. So the delay is a little bit longer. Day 3, he comes home and there was a flood, a water main break when they were working on this street. So not only does he have to go 1 block over, he has to go 3 blocks over, come back down to get home. So the delay is even longer. And on his 4th day coming home, he hits that thing and everything's blocked. There has been trees down. He can't go anywhere. He is stuck. So he's just not getting home. This would be a type 1 block. Let's look at this Mobitz and this Winkelbach thing just to give you some perspective. Why the two names? Well, Winkelbach was a Dutch internist, and he first described the two forms of second degree AV block before ECGs were even invented. But then Mobitz came along, the German cardiologist, and he confirmed these findings. So they both have credit for the naming of second degree AV blocks. Now in a second degree type 1, I mentioned that the delay gets longer, drop, and then you have a Winkelbach. So second degree type 1. Remember, Winkelbach was the first to discover the AV block, so he gets credited with type 1. Type 2 was when the German cardiologist validated it. So Mobitz 1 and 2. Okay, so second degree type 1, we're going to notice that we have an increasing PR interval until all of a sudden one drops. So here we have a prolonged PR interval. There's our first initial 5-minute delay. And we've got to go around to the next block. So we're getting a little bit longer. And in this case, we just don't even have one. This is where the trees are down, all the roads are closed, not getting home. So in second degree type 1, remember here we have our normal PR conduction QRS. Then we come across that sidewalk renovation, so we're a little bit delayed. And then we come across, we have to go around the block. So you see that they're progressively longer. Here's my short delay, a little longer delay. I've had to go 3 blocks today. And now I get a P wave, because remember the problem is not with the SA node. So there will still be a P wave. But my AV node did not send the signal. So there's a missing QRS wave. And because there's no QRS, there can be no T wave. So then we come to the P. Oh, we're starting all over again. Things are working just fine. Let's compare that now with normal sinus rhythm. You can see here we have our normal PR interval, less than 0.20 seconds. and how it's getting longer and longer, and now it's absent. And then it picks up normal, longer, longer. That would be the characteristic feature 1. And then 2 is that there is a missing QRS. The fire did not make it past the AV node. So if we compare this to a first degree block, remember a first degree block will have a 1-to-1 conduction. Every signal sent from the SA node, while it takes a little longer, does go through. Second degree type 1, the signals sent from the SA node take a little longer each time, and then eventually one just doesn't go through. In looking at our analysis, here's another place where we have a difference in atrial rate and ventricular rate. The atrial rate will be regular. The atrial SA node is still going to fire. The problem is that the ventricular rate will be irregular because the AV node is holding on too long. Atrial rate is regular. As you notice, we still have our SA node firing. That's not the problem. Remember, the SA node is still going to continue to fire. It's what's happening with the AV node that is making the difference. So we have a P wave, P wave, P wave, nothing happens. Doesn't matter, SA node is going to fire again. P wave, P wave, P wave. The ventricular rate will be irregular because it's taking longer for those signals to get down. The rates will be different because we're missing a QRS. So our atrial rate will be greater than our ventricular rate. P wave, round and upright. PR interval gets progressively longer, so you're going to have a range, or you can just write progressively longer. Our QRS complex will be normal because the problem isn't with the traveling of electricity through the ventricles, it's just the release before the ventricles. And the QT interval should be normal, but it may also be a little bit prolonged, in which case you'd have to correct it. And the ST segment is flat. So when we get to our wife and husband analogy, the wife is sitting at home, that's the P wave, and the husband, who's the QRS wave, he's sitting at work. Now he comes home a little bit late, first night, a little bit later, the second night, and the third night even later. And then one night he didn't come home, and she's gonna get pissed off, right? So the treatment for this would be pacing. They're gonna need some counseling and some therapy potentially. And then the cycle begins all over again. Now, for a lot of patients they can be asymptomatic with this pattern. And the good news is it's almost always temporary. Once we can find the cause, we can correct that and resume and have them resume back into normal sinus rhythm. If they do become symptomatic, it'll be because of signs and symptoms related to decreased cardiac output. Now, with second degree type 2, we have a consistent delay, and then all of a sudden it just doesn't get through. And so if some P's don't get through, then you have a Mobitz 2. Now, before we go on to our next AV block, it's important to stop here and just take a second to consider that the causes for a first degree and the causes for a second degree type 1 are generally connected to an inferior MI. To the type 2, second degree type 2, this is usually an anterior MI that is associated with it, and this is the only block that actually occurs below the AV node in the bundle of His. So in Mobitz, I kind of have my own little saying, and it travels a bit more, but it's still blocked by 2 structures, the bundle of His and the Purkinje fibers. So as mentioned, the most common cause is an anterior wall MI, and this rhythm, second degree type 2, indicates a problem at the bundle of His or the bundle branches. It is less common but more serious because of the decreased cardiac output. So let's take a look at that. Second degree type 2. Remember the saying was, if some P's don't get through, then you have a Mobitz 2, because the AV signal travels a little bit more, but it's stopped by 2 different structures, the bundle of His and the bundle branches, which are below the AV node. So here we have our consistent P wave that's prolonged, holding, release, T wave, P wave, and the prolong is the same. So we have this consistent PR interval, and then all of a sudden it just doesn't get through. One of those is completely blocked. Let's compare this now to our findings for our analysis. So our atrial rhythm is regular. Again, nothing wrong with the SA node. It is still firing. We should still see a round upright P wave to indicate that the SA node is functioning within normal limits. The ventricular rate, again, will be irregular because we have missing QRS complexes. So it will not be a one-to-one conduction because there will be that gap. The rate of the atrial will be greater than the rate of the ventricles. My P wave, again, talked about. PR interval. Oh, I have here that it says one-to-one conduction. That would be the underlying rhythm. It is not a one-to-one conduction. PR interval may be normal or greater than 20 seconds, or greater than 0.2 seconds. It's usually greater than 0.20 seconds, but it can be normal with still having that gap. QRS will be normal with the occasional missing beat. QT interval will be normal. ST segment should be flat. Let's compare this to normal sinus rhythm. So again, here we have our normal, and I always like to compare to normal sinus rhythm because the key thing here is to identify normal versus abnormal first. So taking a review, P, QRS, T, P, QRS, T. I feel like I'm a cheerleader, woo. Okay, and then I come down here, P, QRS, T, P, whoa, what's happening there? P, QRS, T. And at first glance, it doesn't look like it's prolonged. You really need to do your measurements to make sure you're not missing a beat. When we compare this to second degree type 1, what I want you to notice is the difference in that PR interval. In type 1, remember, it goes longer, longer, drop. There we have a normal one, and then it gets longer and then longer and drops. That's not the same for type 2. Type 2 has a consistent PR interval, but then drops a QRS. The defining features for a type 2 AV block are the PR interval and the missing QRS complex after a P wave. Now, the block may be intermittent or constant. A constant block is measured by the number of times I have a perfusing P wave, a conducting P wave, so a P wave and a QRS, a P wave and a QRS, a P wave and a miss. That would be a 2-to-1 block because I have 2 going through and 1 I miss. When we come to our analogy of Mr. and Mrs. Jones, the wife is waiting at home, and if the husband does come home, he comes home at that consistent time every night. So if you recall from our first degree, he's coming home at 7 o'clock every night instead of 6. But he's coming home every night, every night, every night. One night he decides to stay out with the boys and he don't come home. So this is a second degree type 2. Again, less common, but more severe because it affects that cardiac output. Now the treatment interventions are the same as bradycardia. We're gonna pace. So P stands for pace, A, atropine, consider epinephrine and dopamine. And in our next section, we're gonna go into the third degree AV blocks.